Now we are going to go to Dr. Alan Cohen's lecture. I'm just going to make small changes on the computer setup because Dr. Cohen is going to give us a lecture on advancements of in pediatric brains surgery. And Dr. Cohen, as you all know, is the professor and the director, the chairman of pediatric neurosurgery at Johns Hopkins in Baltimore. He is one of the doyens of pediatric neurosurgery, has worked at the three of the famous centers in North America, at the Rainbow in Ohio, in Cleveland, and then in Boston Children's, and now at Baltimore at Johns Hopkins. He's a past president of the Society of Neurological Surgeons, which is the elite neurosurgical society. He has been the invited guest at the conference of the Congress of Neurosurgery, which is pretty much the highest honor, as far as I know, any neurosurgeon in America have, where they give lectures every day at the conference. So it's a real honor to have Professor Cohen. And not only Professor Cohen is eminent, but his attire during the festive periods will certainly make all his children the happiest. Thank you, Dr. Cohen. Much obliged.
Thank you very much, Naren. Are you able to hear me?
Yes, yes.
Do you just see one slide?
Yes, it says Johns Hopkins Medicine.
Okay, thanks so much. And it's really an honor to be part of this world-class faculty. I wanted to talk about advances in the treatment of pediatric brain tumors. You know, some of this is precision medicine, and there's been a lot of work going on in molecular biology. This is kind of a molecular biology for the non-molecular biologists. I became interested in precision medicine several years ago. I was at the Asian Congress of Neurological Surgery in the men's room, and I saw this sign, "Please urinate with precision and elegance." And that has been an aspirational goal of mine ever since. But I think it also emphasizes the fact that some things are lost in translation when we're talking between the basic scientists and the clinicians. So since the dawn of mankind, we have been interested in trying to classify the world around us, from the earth, air, fire, and water that was believed for thousands of years, even from the pre-Socratic time to the Middle Ages. And for those of you who don't recognize this woman, who looks matronly and very mature, she was one of the landmark people in neuropathology at the Children's Hospital of Philadelphia. And this is Lucy Bailey and Rourke, who in her presidential address to the American Society of Neuropathologists in 1981 commented about categorizing items and how some of these categories change over time. She, in fact, was the person who introduced the term the primitive neuroectodermal tumor for some of these small round blue cell tumors. And she said, you know, even though we categorize people or animals in various states as mammals or reptiles, that's, at any rate, I was talking about Lucy Bailey and Rourke, who was talking about categorizing the universe that we live in, and quoting from an old Chinese encyclopedia, the Celestial Emporium of Benevolent Knowledge. In that, the world was divided, the animal kingdom, into 14 categories, which were those that belonged to the emperor, suckling pigs, stray dogs, those drawn with a very fine camel hair brush, and those from a long way off that look like flies. It seems to be kind of crazy, and I think the great Carolus Linnaeus, the father of modern taxonomy, would probably be turning over in his grave if he'd heard that. He's been the Swedish zoologist in the 1700s that gave us the binomial system of classification, genus, species, Homo sapiens. But I became interested in this again with the recent introduction by the WHO CNS5 of the new classification of tumors that's both integrated and layered, based on the original classification with histological evaluation, immunohistochemistry, and ultrastructure, but adding recent work in molecular biology. And this was an article by David Lewis, who is the neuropathologist in chief at Mass General Hospital. And it's a revolutionary introduction of a classification scheme that has been with us since 1979, adding these molecular categories. There are now 22 newly recognized entities in this classification. And in fact, the term entity has been replaced by type, variant has been replaced by subtype to make these more consistent with other non-neurosurgical or neurological pathologies. Roman numerals were replaced by Arabic numerals. And that's just some of the housekeeping stuff. But next generation sequencing, which we heard about a little from Dr. Buffet, which is pretty high tech, looking at molecular alterations that may enable us to target the various tumors, is not available worldwide, but is now introduced in this layered fashion. And that means that when we get pathology back, we're often working with the histology, and we have to make therapeutic decisions before we have the actual final diagnosis, something that's impacted us worldwide. One of the trade-offs of this new scheme is the names can be lengthy and cumbersome. And for example, one of the terms is diffuse pediatric type high-grade glioma, H3 wild type and IDH wild type. That doesn't roll easily off the tongue, as does desmoplastic myxoid neoplasm of the pineal region, SMARCB1 mutant. We're gone are the era of gliomas and medulloblastomas. The advantage here is that there are mutations that can be targeted. The disadvantage is you need an encyclopedia to be able to remember the names of some of these tumors. So pediatric brain tumors are the most common solid neoplasms in children. They're the leading cause of cancer death in this group. The CNS tumors account for 20% of childhood malignancies, and they're second only to leukemia in frequency. There are tremendous advances in this field that have led to improved survival and improved quality of life for some children, but for others, the prognosis remains dismal, and cure often comes at a cost. Here's a survival graph of a glioblastoma, and you can see the survival rate is still quite poor overall. And survival comes at a cost with some, as you heard from Dr. Buffet, from radiation therapy, harboring long-term sequelae from their treatment, where he was talking about attempts to de-escalate therapy with chemotherapy in this field. In terms of the epidemiology, there's really only one factor that has been associated with increasing the risk of brain tumors in children, and that's ionizing radiation. There have been some studies in atopic conditions showing that they may decrease the risk, but there are some contradictory work, and that's still being evaluated. It's very interesting to go back and look at the history of this field and how much has been accomplished over the past century or more. This is the operating room of W.W. Keene, William Williams Keene, at Thomas Jefferson Hospital. And he, in 1887, did one of the first operations in the world, removing a meningioma from a 26-year-old carriage maker in Pennsylvania. It was a successful operation, but does anybody recognize, how about the people on the other side of the Atlantic? This fellow here, this is Rickman Godley, and Godley is credited as removing the first primary brain tumor in history in a 25-year-old farmer from Dumfries, Scotland. And Godley was about 35 years old at the time. He was the nephew of Joseph Lister of antiseptic fame. And he worked at the Hospital for Epilepsy and Paralysis. This was in Regent Square in London, a 3-story building that's subsequently been torn down. It's been moved, I believe, to Maida Vale. The diagnosis was made by Alexander Hughes Bennett. They published this subsequently in the British Medical Journal on the basis of the neurological findings only. There was no CT or MRI. This was in 1884, and July 27, this was actually in November 1884, where they made a diagram. Because the patient had seizures, they localized this to the right Rolandic brain, and this was a diagram that how they found this. And this was an operation that he did in a 2-hour period with um, observers, including Hewlings Jackson and Victor Horsley, David Ferrier, and Hughes Bennett himself. Apparently, this is a later procedure done by Godley, but apparently they did finger dissection, removed the tumor. There was a lot of blood that came out. It was a glioma. The patient developed a high fever and a putrid smell from the wound on the 4th postoperative day, and actually died of a wound infection on the 28th day. So it was overall not a terribly successful operation, but it was a landmark because this was the first brain tumor operation in history. And Godley went on to write a biography of his uncle, Joseph Lister. Now, anybody recognize this fellow? Those of you from the other side of the Atlantic, because this is the person who should be credited as performing the first brain tumor operation in history. And this was William McEwen. He was 31 years old when he did the procedure. He had been born on the island of Bute in the Firth of Clyde in Scotland, and was working at the Royal Infirmary in Scotland. And this was his personal diary when he met a 14-year-old woman, a girl named Barbara Watson. And his diary said that she had obscuration of intelligence, slowness of comprehension, want of mental vigor, and then she had seizures and of the right face and arm. He documented this quite extensively in this journal. And he had operated on her previously a year earlier for a tumor of the scalp over the left eye. And this time he localized the tumor to the left frontal lobe. This is a picture I found of her in her postoperative state. He also was a student of Lister, used carbolic acid for his preparation. And he did a trephine and removed the tumor that was stuck to the meninges, likely a meningioma. Here he is working later in Scotland. And here he is working. This is McEwen. This was his assistant, Pringle. And this is a picture he published in the British Medical Journal, localizing the tumor. And here he presented this at a meeting of the British Medical Association years later, noting that the reason that there was so many failures previously is that the brain was poorly understood, the mysterious dome of thought, or a dark continent, he described the brain, that could be accessed only by groping in the dark. And McEwen attributed his success to 2 factors. One was the antiseptic technique. This was his mentor, Joseph Lister. He boiled the instruments and prepped with soap, water, turpentine, methylated spirits, and carbolic acid. And the other was localization that he learned from the reigning neurologists of the era. And McEwen went on to become the Regius Professor of Surgery in Scotland. He was knighted by the Queen. He was actually offered the job of chair of the Department of Surgery here at my own institution, Johns Hopkins, but he turned it down because they wouldn't allow him to have control over the nursing staff in the OR. He was sort of a cantankerous guy, and I think he's gotten little credit for this because he lived in the shadow of the people working in London. He was a Renaissance man, and at the end of his life, his last book was on the growth and shedding of the antlers of the deer in 1920. Apparently they shed their antlers and regrow every year. And here he was a year before his death as the Regius Professor of Surgery. Things have changed pretty dramatically since McEwen did this operation back in 1879. And I wanted to talk a little bit about the clinical presentation of brain tumors in children, because I guess perhaps the major theme of what I wanted to say is that pediatric brain tumors are different from those in adults, both in biology and behavior. We diagnose brain tumors in infants with difficulty because they're pre-verbal. They can't talk about headache or other symptoms. But things we look for are macrocephaly, a tense fontanelle, sunset eyes, loss of milestones. Some of the things like irritability, vomiting, weight loss are more likely to be caused by other conditions. And the average pediatrician sees maybe 1 or 2 brain tumors in an entire career. So it's something that's not widely understood by those outside the field of neurology. A unique presentation in kids and infants is the diencephalic syndrome with failure to thrive and weight loss, emaciation in the setting of normal caloric intake that can be related to a tumor of the hypothalamus and thalamus. In toddlers and older children, we can look for papilledema, sixth cranial nerve palsy, which is a long nerve, can be a false localizing sign. And the location varies with age. In young kids, these are supratentorial, between 4 and 10 years, more likely infratentorial, and then they go back to be supratentorial as the kids get older. Supratentorial tumors can present with headache and seizures. They can have focal signs depending on the location. This was a child who had seizures, and this is a disembroplastic neuroepithelial tumor, a cortical tumor that we resected in the child who presented with seizures. Seizures are the presenting sign of a brain tumor in 13% of cases, but interestingly, a brain tumor is the cause of seizures very rarely. Most kids who have seizures do not have a brain tumor, probably fewer than 3%. Supratentorial tumors that are suprasellar involve the optic apparatus, the hypothalamus. They can present with endocrinopathies. This was an 18-month-old girl who had precocious puberty, and we found this tumor between the optic and carotid, which was a hypothalamic hamartoma, which we removed, and that reversed her precocious puberty. Hypothalamic hamartomas can also present with an unusual type of seizures, gelastic seizures or uncontrolled laughing, or dacrystic seizures, uncontrolled crying. And so the clinical exam that we're looking at is different for kids than adults. And infratentorial tumors are more likely to present with nausea, vomiting, here headache, ataxia, papilledema. The tempo of the disorder can also be helpful. A medulloblastoma will usually have a shorter history, an astrocytoma, perhaps a longer one. Kids who may present with vomiting without headache might suggest an ependymoma in the area of the area postrema, in the floor of the fourth ventricle. This was a pylomyxoid astrocytoma. Here's rostral in the posterior fossa of a 9-year-old girl. She had bilateral facial weakness, and this thing involved the floor of the brainstem. Neuroimaging has made major advances since the era of McEwen. We can now take some of the guesswork out of operating. And this was an advertisement for a new neuroimaging center at the University of Southern California. Unfortunately, it's the little things that can get you in trouble, and that is the artist put the brain in the head backward. And so in art and in neurosurgery, it's the little things that can cause big problems. But neuroimaging has made major advances in our field, and the main workup in a child that we, with a brain tumor, if we can, is an MRI without and with contrast. This was an 8-year-old patient of mine who presented with diabetes insipidus, visual loss, and headache, and has this big enhancing tumor in the suprasellar area. And in the modern era now, we found with examination in the laboratory studies that there was mild elevation of the beta human chorionic gonadotropin, both in the serum and CSF, and that with the synchronous presentation of this lesion in the suprasellar area and pineal region gave us the diagnosis of a germ cell tumor. And we worked on a protocol from the Children's Oncology Group and treated her without even a biopsy. And here with radiation and chemotherapy, 1 year later, the tumor melted away. We don't usually operate without a biopsy, but there are protocols now because of some of the sophisticated laboratory examinations we have that we're able to do that. And some of the other advantages that we have in imaging here is the SWI, the susceptibility weighted imaging in this young child with an atypical teratoid rhabdoid tumor, a devastating tumor, showing the intratumoral hemorrhage that we can see on imaging. Diffusion weighted imaging looks at the dispersal of water. It turns bright and highly cellular malignant tumors. It's not always the case because that can also be seen in benign tumors like epidermoids because of the desquamated cells. Diffusion tensor imaging can show us fiber tracts and help plan surgery in eloquent areas. Functional imaging is not something that we use that often in children because it requires cooperation. This was a 17-year-old boy with an intrinsic lesion in the left temporal lobe. And we used functional imaging, actually, and an awake craniotomy. You also don't use a lot of awake craniotomies in kids because it requires cooperation. This is a child who was cooperating, then decided to try to wake up and get out of the pins during the operation. But fortunately, we were able to get him back and sedated. And MR spectroscopy, it's a highly interesting field. The N-acetyl aspartate is a neuronal marker, and choline is a membrane turnover marker. And in general, pediatric brain tumors have an increased level of choline compared to NAA. Here's a normal spectroscopy. Myoinositol is a glial marker. It can be seen in choroid plexus tumors and ependymomas, and taurine sometimes in medulloblastomas. It's a very interesting field. I don't think it's made a major impact on the way we practice clinical neurosurgery. And then there are multiple surgical advances since the era of McEwen. He did not have the opportunity to have intraoperative MRI. This is a nice tool. There is a saying that a fool with a tool is still a fool, but it is a very nice tool, and it allows us to see what might be hidden around the corner. And in kids, it enables us to obtain a postoperative image without sedation. Again, it's not I use it sometimes, but it takes extra time in the operation, and it's not available worldwide. Image-guided surgery here with frameless stereotactic navigation is like a GPS system for the brain, takes some of the guesswork out of surgery. And fluorescence-guided surgery, this is an adult study of an oligodendroglioma in the frontal lobe that lights up with 5-aminolevulinic acid, a protoporphyrin. We've been working with tazularidine as part of a Pacific Pediatric Neuro-oncology Consortium. This is a synthetic analog of the scorpion venom from the Israeli Deathstalker scorpion. It's biologically inert, but when it's combined with indocyanine green, it lights up tumors. And we're doing a study on this in pediatric case. This is the Deathstalker scorpion. He's got a cute face, but there's a similarity in my mind to our former Attorney General, William P. Barr. I don't know whether you guys would agree with that, but this is what happens in a cerebellar astrocytoma. Here's the tumor, and it lights up the tumor and not the surrounding brain. So this is being investigated as an agent for fluorescence-guided surgery. And then we have minimally invasive techniques that we can use to look right through the patient. Here, the microscope, of course, is a major advance. Endoscopic surgery, exoscopic surgery. Here, a colloid cyst of the foramen Monro can be removed in selected cases with minimal trauma. And those are some of the adjuncts. And the field of pediatric brain tumors is extensive. So I wanted to just go over a few of the major representative tumors that we deal with, the low and high-grade gliomas and ependymomas, and the embryonal tumors, as you heard from Eric, mainly medulloblastomas. This is an ependymoma, a very vascular tumor of the fourth ventricle in an 8-year-old girl. Low-grade gliomas are the most frequent brain tumor of childhood. In adults, supratentorial primary brain tumor more likely to be a highly aggressive glioblastoma, but low-grade gliomas are the most frequent. They represent a third of child brain tumors if you include the glioneuronal and neuronal tumors. And these are different from our adult counterparts. The adult low-grade gliomas often have mutations of IDH1 and 2. That's not the case in pediatric tumors. Adult low-grade gliomas are frequently transforming into higher grade tumors, whereas that's not the case in pediatric tumors. It's less common. This is a 5-month-old patient of mine who presented with dancing eyes. It was a condition called spasmus mutans. And here is a tumor, a suprasellar tumor, which we manage by endoscopic debulking, drainage of the cyst, and chemotherapy. In general, the treatment of pediatric low-grade gliomas is to establish a tissue diagnosis and maximal safe resection. That's not always the case for tumors of the optic pathway where we don't want to be surgically invasive. This was a child who presented with seizures, and we called this a profile of a glioma because here's the glioma. It was a pilocytic astrocytoma that had eroded the undersurface of the skull. You can see the vein here and the two areas on either side where the tumor had eroded the undersurface of the skull. And in general, we like to remove these tumors, but Not all of these low-grade gliomas, particularly those that may be deep-seated in the midline, can be removed. And sometimes observation is a very reasonable way to treat these, because these tumors, again, are different from adult low-grade gliomas. And as you heard from the prior speaker, we often have protocols for chemotherapy to eliminate some of the long-term toxicity of radiation. There was an international study by Stockland of 5 years progression-free survival of 69% in pediatric low-grade gliomas and an overall survival of 95%. And the risk factors were for progression: young age, incomplete resection, fibrillary histology, and hypothalamic location. Another difference is temozolomide, the alkylating agent, has been effective for adult low-grade gliomas, giving an improved survival over radiation alone. That survival has been less clear for children. And in one study in children, there was a progression-free survival of only 17% at 4 years, and 70% of those patients had to receive another agent as well. Another study by the Children's Oncology Group found that temozolomide was not effective in kids. It doesn't seem to have the same effectiveness in children as adults. Bevacizumab has been used with and without the topoisomerase inhibitor irinotecan for salvage therapy, and it works. You can get rapid control, but there is tumor progression when the drug is stopped, and there are considerable side effects that can be associated. And one of the major interests in pediatric low-grade gliomas is the pathway of the mitogen activated protein kinase signaling. The majority of low-grade gliomas are associated with alterations in this pathway, including the BRAF mutation or fusion, the NF1 mutation, fibroblast growth factor receptor 1 mutation, and the NTRK family fusions. And here, coming from the normal cell to the nucleus, BRAF, if it is mutated, will allow uncontrolled activation of the MAP kinase pathway, leading to tumor growth. This is also called the RAS, RAF, MEK, ERK pathway. And the importance is that BRAF can be targeted. This mutation can be targeted, and there can be MEK inhibitors and BRAF inhibitors, which are being investigated for the control of these low-grade gliomas. Here is what happens in the normal signaling pathway. And again, when BRAF is mutated, or it can also be fused, there can be constitutive activation of the downstream pathway, leading to tumorigenesis. And again, the importance of this particularly in the 2021 WHO classification is that it enables us to develop novel targeted therapies, some of which work and some which don't. Here's an example of using a BRAF inhibitor in a patient with a posterior fossa astrocytal low-grade glioma before and 8 weeks after treatment with dabrafenib, a BRAF inhibitor. And so that's, I think, the wave of the future. And in addition to this point mutation in BRAF, there is a fusion with KIAA 1549. It's a large gene of unknown function. This happens on chromosome band 7q34, the site of BRAF. And this is something that is very common in pilocytic astrocytomas. In fact, that's the most common BRAF abnormality in pilocytic astrocytomas. 80 to 90% of them have this fusion. It's a tandem duplication at chromosome 7q34, and it can be targeted. As we heard from Mimi, one of the speakers on day one, that it's important to recognize that patients with a BRAF fusion should not be treated with BRAF inhibitors because there can be a paradoxical growth of the tumor. But this is something that can be effective in patients with pilocytic astrocytomas for targeting. Here's an example of a pilocytic astrocytoma in a 15-year-old girl presented with headache and has a solid and cystic lesion in the right temporal lobe. The pilocytic astrocytoma is the most common astrocytoma of childhood, and it represents 20% of brain tumors in children under the age of 20 years. It can be targeted. There has been a study with selumetinib, which is a MEK inhibitor, which was successful. And now there are 2 phase 3 trials, clinical trials using selumetinib, a MEK inhibitor, for treatment of newly diagnosed and recurrent or refractory pilocytic astrocytomas, either with or without associated neurofibromatosis type 1. I think it's an important issue because while most of these tumors are indolent and benign, 20% of them can progress either with local recurrence or refractory treatment to standard chemotherapy. And of note is that there are several genetically determined gliomas, low-grade gliomas, that are associated with some of these mutations. The neurofibromatosis type 1, here's a malar angiofibromas in a patient with tuberous sclerosis. But this is a 14-year-old boy with headache, and papilledema, and this intraventricular tumor that we removed through a transcallosal approach that proved to be a juvenile pilocytic astrocytoma. NF1 patients this is a autosomal dominant condition where there's a mutation of the NF1 gene on chromosome 17q, and that leads to the NF1 gene encodes neurofibromin, which is a tumor suppressor protein. When this is activated in a mutation, we lose neurofibromin, and there's unregulated activation of the downstream MAP kinase pathway leading to tumorigenesis. So we can learn more about these molecular pathways looking at some of these genetically determined cases. This is a patient with tuberous sclerosis, a genetic mutation of the TSC1 or 2 gene. And this is related to a mitogen, it's an mTOR pathway disorder. These subependymal giant cell astrocytomas occur in 15% of patients with tuberous sclerosis. When they enlarge to block the foramen of Monro, they can be symptomatic. This is one that we remove through a transcallosal approach, but they can also be treated with mTOR inhibitors, sirolimus, which is the mammalian target of rapamycin. It's an inhibitor, a macrocyclic lactone, and this can be effective in controlling these. It's an expensive drug. It works, but these tumors can grow again if the drug is stopped, and there can be side effects, particularly those related to immunosuppression. And then another interesting genetically determined pediatric tumor occurs in Noonan syndrome, which is considered a RASopathy, something involving the MAP kinase pathway. This was a patient of mine who had seizures, and this DNET, a dysembryoplastic neuroepithelial tumor. Noonan syndrome is characterized by short stature and cardiac abnormalities. They can have hematologic abnormalities, as this child did, and it can make the surgery a little bit more difficult. But I think we can learn more about some of these molecular mechanisms by looking at some of these genetically determined tumors. High-grade gliomas, the next category, account for about 10% of pediatric brain tumors. They have a very poor prognosis, and 70% of children with this disease die within 2 years of diagnosis. It's interesting, we all know the term glioblastoma multiforme. It was coined by Cushing and Bailey in 1926. They wanted to give it a name. It ultimately was changed to glioblastoma multiforme, and over the years, the multiforme was dropped. And now the term glioblastoma in the CNS5 WHO 2021 classification is limited to only a specified type of adult glioma, a diffuse wild type IDH wild type glioma in adults with specified malformations of either the TERT promoter gene or the EGFR or a gain of or loss of chromosome 7 or 10. It's a very specified diagnosis, and the term glioblastoma in WHO 2021 no longer is listed in the lexicon for pediatric brain tumors. That is because of some of the advances in the understanding of the histone gene based on work done in 2012. And this is these are beads on a string. Histone is a gene that helps remodel DNA to be able to have it packaged in the nucleus and compacted. it turns out that there are now 4 types of pediatric high-grade gliomas that are recognized. And these include the diffuse midline glioma, H3K27 altered, the diffuse hemispheric glioma, which is H3G34 mutated, the diffuse pediatric glioma that is H3 wild type and IDH wild type, again, terms that don't roll easily off the tongue, and an infant type high-grade glioma, an infant type diffuse glioma. This is an example of a diffuse midline glioma. It used to be called DIPG. Sometimes it's a uniform, sometimes it enhances like this, a child who came in of mine with cranial nerve problems. This is these mutations of the histone gene occur in 80% of diffuse midline gliomas and 40% of diffuse hemispheric gliomas. And there's a substitution of one amino acid for another. And it's a tumor that has a dismal prognosis, again, because it can't be resected. We're relying on treatment. Main treatment is palliative radiation, but there are new protocols being evaluated. This is an example of a diffuse hemispheric glioma. This has an H3G34 mutant. The substitution is on a position 34 in this case, and it's a different amino acid substitution, also an aggressive tumor that can have mutations of other genes, ATRX and TP53 as well. Here, a child who had seizures, and this hemispheric weakly enhancing tumor. And this is the H3 wild type and IDH wild type. This is a child who had papilledema, headache, and this diffuse tumor that spread rapidly to both hemispheres. There are 3 subtypes of this tumor, again, on the molecular biology. The one with the MICN amplification has the worst prognosis, and the one with an EGFR mutation has the better prognosis, but a highly aggressive tumor. And as I said, the term glioblastoma is no longer in the lexicon. So the WHO CNS5 is something that's difficult to comprehend because it's so wordy. But I think it's a transition. I think these things change year by year, but this is what we're working with now. And this is this new term, infant type hemispheric glioma. This is a patient an infant with headache and vomiting. These tumors have mutations, are actually fusions of the receptor tyrosine kinase gene. And the importance of that is that they can be targeted. Those with the RTK fusion tend to have a better overall prognosis than those not. Again, an evolving field. A word about temozolomide, just as in low-grade gliomas. This is a drug that is effective in adult tumors, but not as much so in pediatric tumors. And it may be that in the trials where this was evaluated, that the failure of temozolomide was also related to an increased production of the MGMT promoter, and by using lomustine in addition with temozolomide, people have found a better result. But again, something being evaluated. Again, a difference between pediatric tumors and adult tumors is that the adults tend to do better with temozolomide. Targeted therapy is something that we've been looking at, and the reason is because there's really been no major advance in the treatment of high-grade gliomas in the past 50 years. We've got a lot of things going on, but the 3-year event-free survival for patients with high-grade gliomas is about 10%, and the overall survival about 20%. And for diffuse midline glioma, untreated, the median survival is 4 months. And if you add radiation, it may go up to 11 months. So with all this targeted therapy, there is still much work to be done. And in the targeted therapy for high-grade gliomas, one of the things that's on the landscape is the HDAC inhibitors, the histone deacetylase inhibitors. And again, histone is involved in packaging. This is an epigenetic process by the DNA is packaged and compacted to go into the nucleus. HDAC inhibitors such as panobinostat have been effective in slowing the progression of selected tumors. There's another drug, fimobinostat, that we're involved in a Pacific Pediatric Neuro-oncology Consortium study that may have an impact in slowing the growth of these tumors, but there's still a lot of work to be done. So that's, again, a quick tour of high-grade gliomas. Adding one more thing on the horizon, ONC201, which is a dopamine receptor antagonist that has been used in several cases of high-grade gliomas, diffuse midline gliomas, and may have some effect. Again, these are all ongoing studies. I want to talk about two more tumor types. One is the ependymal tumors. These are the third most common brain tumor of childhood, and 2/3 of them are intracranial. Two-thirds of the intracranial ependymomas are in the posterior fossa. This is what this looks like in histology. This is a pseudo rosette with these cells forming around a vessel. So CNS5 has changed the nomenclature. This is a child of mine who had back pain and leg weakness and had this myxopapillary ependymoma of the phylum Terminale. Here's the phylum, which we removed. This used to be a WHO grade 1 tumor. It's now considered WHO grade 2 because its behavior has been considered more like some of the other spinal cord tumors, whereas the subependymoma, a very low grade tumor, is still considered grade 1. But in terms of the grade 2 and 3 tumors, histology is not so helpful in making a diagnosis. And now we have an alphabet soup of how to categorize these tumors. And for the supratentorial ependymomas, we look at Relay fusion versus the YAP1 fusion. The Relay fusion is actually C11ORF95 Relay. It's now changed its name to ZIFTA because the ZIFTA gene confused with more ligands than Relay. That's the most common gene abnormality in supratentorial ependymoma. It occurs in 70% of cases. The other is the YAP, or the YES-associated protein, less common. This is a child of mine who had a very aggressive ependymoma. It was Relay fusion or ZIFTA fusion positive, treated with surgery and radiation. It's been felt that the YAP, that the Relay tumors, or now called ZIFTA fusion tumors, are more aggressive than the ones with YAP. But a recent study by the Children's Oncology Group found that if these kids were treated with conformal radiation, that difference in survival goes away. So again, ongoing work in the molecular biology field. In the posterior fossa ependymomas, these are classified now according to methylomic profiling in terms of posterior fossa A or B. And the posterior fossa A tumors are their H3K27 hypomethylated. This is an example of a young child with a laterally placed tumor who had a posterior fossa A tumor. It's been felt that these tumors have a worse prognosis than posterior fossa B. They tend to occur in younger children. But in a study that Tom Merchant did, if these patients are treated with conformal radiation, the difference in survival seems to go away. So radiation therapy is something that is associated with a lot of long-term survival complications, but in conformal doses with careful use, it's being used in children as young as 1 year of age. And again, the landscape is changing. This difference between PFA and PFB may not be real. So the ependymoma treatment is something that we're continuing to evaluate. Chemotherapy has not made a major advance in the treatment of these tumors. The mainstay of treatment is maximal safe resection with radiation therapy. Still, the overall survival of kids with this tumor is about 50%, the progression-free survival of 30%. So in selected locations, this is still a bad tumor looking for a better targeted therapy. And the last category I wanted to discuss was CNS embryonal tumors, of which medulloblastoma is the hallmark. These used to be PNETs, primitive neuroectodermal tumors, by Lucy Rourke. And then a study by Scott Pomeroy from Boston Children's using DNA microarray analysis found that these small round blue cell tumors were actually multiple different types of tumors. And in 2016, the WHO eliminated the term PNET, and these are called now embryonal tumors. And there are a number of other variety of these that are fairly aggressive. But the most common malignant tumor of childhood is the medulloblastoma, affecting 60% of childhood embryonal tumors. 70% are in children under the age of 10, and a third occur in under the age of 3. Here's a heterogeneously enhancing tumor in a 9-year-old patient of mine. Interestingly, about the origin of the term medulloblastoma, again, it was coined by Cushing and Bailey, and that was in 1925. Of note, the term medulloblastoma has stayed with us through the years, even though there has never been a cell characterized as a medulloblast. So that was the power of Cushing, longstanding. And the WHO CNS5 categorization now is it's a hybrid. These are histologically defined or molecularly defined. You can see these small round blue cells, but when we look at morphology, you heard from Dr. Buffet about the classic desmoplastic nodular, extensive nodularity, or large cell anaplastic. Formerly, this is the way we looked at these tumors. We looked with the Chang classification, and in general, the desmoplastic nodular and the extensive nodularity tumors were ones that had a better prognosis. But things have changed now, and they've changed even since Pomeroy and Michael Taylor have categorized medulloblastoma genetically into multiple different subgroups. And now, by WHO 2021, there are 4 subgroups of medulloblastoma: Wnt activated, sonic hedgehog activated with TP53 wild type and mutant, and then the non-Wnt and non-sonic hedgehog activated. There's a lot of factoids going on here, but this last group used to be called group 3 and group 4. And this categorization is based, again, on a lot of the molecular profiling that we didn't have before, some of which will translate into effectiveness in treatment and some won't. But I think it's difficult but important to try to keep up with the terminology. These are some of the molecular subgroups. A patient with a Wnt tumor, these can be midline, but often involve the cerebellar peduncle. Sonic hedgehog often can involve the cerebellar hemisphere. And here's a midline non-Wnt, non-sonic hedgehog medulloblastoma. This is a table from Michael Taylor talking about the Wnt sonic hedgehog group 3 and 4. Of these tumors, Wnt is the rarest tumor with the best prognosis. These are the other tumors. The Wnt tumor, these tumors affect boys and girls, but the group 3 and 4 actually affect boys much more commonly than girls. And the Wnt activated tumors are usually classic in histology. And the molecular abnormality that we see here is activation of beta-catenin in the cell nucleus, which drives the tumorigenesis. And so that's the molecular finding. They also can have a monosomy of chromosome 6 and other abnormalities, including something from the APC, the adenomous polyposis gene deletion. That occurs in about 85% of these cases. This is a picture of a wingless wasp. The wingless, this is wingless integrated, is that what it stands for? It comes from the term to describe the genetics of the Drosophila fly. This is a male fly. I'm sorry, this is a female wingless fly. The male wasps have wings and they mate in the air. The male holds the female, but that's the derivation of wingless. The importance of these is that these tumors have a very good survival, in some series 97% survival, and it may be related to the fact that there's a breakdown of the blood-brain barrier. Sometimes these are tumors that can present with hemorrhage, and that breakdown of the blood-brain barrier may explain why these kids do better. Maybe the chemotherapy can penetrate the area more effectively to the extent that there's protocols to try to de-escalate therapy for the wingless medulloblastoma. The sonic hedgehog activated medulloblastomas account for about 30% of these tumors. They're located more laterally. They affect kids. The histology is more likely to be desmoplastic nodular or medulloblastoma with extensive nodularity. The abnormality here is in the sonic hedgehog pathway with a deletion or loss of the tumor suppressor patched 1, and that occurs in almost half the kids. There can also be an abnormality of the proto-oncogene SMO or smoothened. In the new classification, the sonic hedgehog activated medulloblastomas that are TP53 mutated, only about 10% of them have a worse prognosis. But again, this is impacting how we're going to go after therapy. One of the pathways is the smoothened pathways that can be inhibited with drugs like vismodegib and sonitigab. So again, we're living in a molecular world. And the final one is the non-Wnt, non-sonic hedgehog activated patients. This is a patient of mine. He actually had an intratumoral hemorrhage. Again, this is frequent with the Wnt tumors, but the Wnt are a less common group. This is what is now the combination of group 3 and group 4. These are tumors that are more likely to be in the midline. They affect boys more than girls. They have a pretty poor prognosis. The group 3 tumors are the worst, and they have a 5-year overall survival of maybe 50%. The group 4 have a 5-year overall survival of about 70%. Newer protocols are being developed, or we have the Head Start protocol. I heard about a little bit about this from Dr. Buffet for young kids in an attempt to eliminate or delay radiation therapy. We use high-dose chemotherapy with stem cell rescue. But both of these are still aggressive tumors. And here is the hemorrhage in this tumor, non-Wnt, non-sonic hedgehog. Interestingly, medulloblastoma can be associated with hereditary predisposition syndromes, and I think we can still learn a lot about this tumor by studying these genetic syndromes. This is Turcotte syndrome, and that's the familial colorectal polyposis syndrome, and that's associated with Wnt medulloblastomas because of an abnormality of the APC gene, the adenomatous polyposis gene. That's on chromosome 5q. Something that can be targeted. That is the Gorlin syndrome now is associated with the sonic hedgehog variant of medulloblastoma. Gorlin syndrome is the Nevis syndrome, and it's associated with a germline mutation of patched 1, the basal nevoid polyposis syndrome. The basal nevoid carcinoma syndrome. This is Gorlin syndrome. But kids with Gorlin syndrome can get these jaw cysts, these cysts in the jaws. They can get multiple problems, but the patched 1 gene mutation on chromosome 9q is associated with the development of medulloblastomas, and it can tell us a little bit more about the molecular biology of this tumor. And then finally, Leaf-Romani, which is a defect in the TP53 gene, which can lead to multiple aggressive tumor formation, can be associated with sonic hedgehog. So the treatment of medulloblastoma is interesting because this is back in 1954 when Frank Ingram and Donald Mattson, who founded the field of pediatric neurosurgery, wrote in their textbook in 1954, the Neurosurgery of Infancy and Childhood, that to our knowledge, there's no patient with this lesion ever cured, and it seems unlikely that one ever will be with our present therapeutic methods. And that was the case back in 1954, and again in their second edition in 1961. This was their textbook, and Ingram had a penchant for the astrocyte. He gave his residents ties with a picture of the astrocyte on them. But fortunately, that's no longer the case. And now in some series, up to 70% of medulloblastomas can have a long-term overall survival. And the conventional treatment is maximal safe resection with craniospinal radiation and chemotherapy. Here's a medulloblastoma poking into the vallecula here in one of my young patients. And the future treatment is now focusing on de-escalation of treatment for those kids with the Wnt tumor with such an excellent prognosis, targeted therapy for directed at the smoothened and downstream pathways in sonic hedgehog, and risk-adjusted therapy for non-Wnt, non-sonic hedgehog aggressive medulloblastomas. So there's a lot of factoids there, but that's a tour of pediatric brain tumors. And I think the important takeaway points are that pediatric brain tumors are different from those in adults. They have a different biology and behavior, and that there have been advances in DNA methylation and genome sequencing that have improved our ability to diagnose and categorize these brain tumors. There have been advances in surgery and adjuvant therapy that have led to improvements in survival for many kids with these tumors. And there are a number of molecular advances and targeted therapies that are being investigated, and they're intriguing, although to date they have not, I believe, made a major impact in the field. But I think there's reason to believe with a better understanding of these tumors and with molecular directed therapy, targeted therapy, that we're going to have an ability to have improved survival in some of these tumors that we can't control, with improvement in the side effects and long-term complications of therapy, which remain substantial. Thank you very much for your attention.
Thank you very much, Dr. Al Cohen. That was a fantastic overview of the advancements in pediatric tumor management, and it's a very positive lecture. I just want to ask you in terms of what you call there's Professor Andre Grottenhuis, and we have got neuro-oncologists here as well. I know that we are running slightly behind time, but I think this is a really unique opportunity. But in 5 years' time, in 10 years' time, Dr. Al Cohen, where do you see the neurosurgery input? Is it going to be like aneurysm surgery, that we are going to have complex cases and it's going to be mainly neuro-oncological? What's your thoughts, Dr. Al Cohen?
Well, I think that, I tried to cover a lot of information about a big field, and there have been significant advances improving the safety and efficacy of surgery for tumors. But I think the main advance is going to be in methylome profiling and genomic sequencing. I think we're going to be able to do things that we couldn't do with minimally invasive techniques. And there's always going to be a role for the neurosurgeon in making the tissue diagnosis. But I think the improvement in outcome is really going to come from the molecular biologists. And what I was trying to show is the paradox here, that both the molecular biologists and the clinicians are rowing in the same direction, but not necessarily talking to one another. This new scheme, I think, is going to be helpful. It's probably going to change within a couple of years again. But we need to be able to be aware of what is being done in the laboratory to be able to translate it to the clinic. And it's being done, but I think there's still a lot more work to be done. But I think the future is going to be in molecular biology.
Thank you. Thank you, Dr. Cohen. If Dr. Eric Buffet and Dr. Steve Lowe is there, Dr. Buffet, do you have any thoughts on how we are going to progress in the next 5-10 years from what you have seen, the way the travel has been? So what's your thoughts in what's the future going to hold?
So I think neuro-oncology has been very interesting in this aspect, because particularly in the glioma group, you can see that we have observed an introduction of a number of targeted treatments such as MEK inhibitor, BRAF inhibitor, NTRK inhibitor, now FGFR inhibitor. So all this comes from a better knowledge of the identity card of these tumors. And hopefully, so we have seen the issue of the diffuse midline glioma and their signature with the HK27M mutation. The dream is that we find a drug that targets this type of alteration, and we can eventually treat successfully, finally, this terrible disease. It's not yet clear whether we will see the same evolution in embryonal tumors such as medulloblastoma. We have seen 10 years ago the introduction of sonic hedgehog inhibitor with very little success and concern about the toxicity. But it's clear that there is a trend now toward a sort of progressive change from chemotherapy and radiation-only approach to a more targeted treatment. And of course, the issue is, will this be a privilege of high-income country, or when is this going to come into the practice in all countries around the world, because there is a cost associated with this. So I'm sure that Daniel and Ibrahim can comment as well on this.
Thanks. Dr. Kodomi, do you want to comment, please? Thanks. You have to
unmute Ibrahim.
Okay.
Thanks.
Okay. So I have unique perspective because I worked in a developing country as a neuro-oncologist, and I worked in one of the most advanced places in the world. We have no problem getting any targeted therapy. Part of my problem with this, and keep talking about targeted therapy, it really make us deviate about the most important therapy to cure low-grade glioma, and that's in neurosurgery. Our neurosurgeon, Rick, always recite that paper, I forgot the main author, where you can cure more than 70% of low-grade glioma by neurosurgery. And I always tell my colleagues in developing countries, if you really have $120,000 to spend on 1 year of selumetinib, please spend it on sending a neurosurgeon to one of the advanced countries or centers to, thank you, Daniel Wissoff, thank you. To train and come back and be a good neurosurgeon, and that neurosurgeon will not only cure low-grade glioma, because I assume if you're good in curing low-grade glioma, you will be good as a neurosurgeon and other things. That's my main problem with talking too much about targeted therapy. I use it. I'm making a career of targeted therapy. I'm not against it. I really think we always have to emphasize in neurosurgery first.
Thank you, Dr. Kodomi. And Dr. Stephen Lois is once again very pro neurosurgery oncologist. I always consider him in my own mind as a neurosurgeon who's a neuro-oncologist. And Dr. Lois, where do you see the future, and where do you see the importance of surgery and these targeted therapies and chemotherapies, and in terms of money as well, resources as well?
I think the comments have been entirely accurate. You can manage most of these patients with surgery, and if you are trying to use your money most efficiently, then training people appropriately is going to be more effective. But pharmaceutical companies charge what they can and will. Over time, you hope that those costs will come down and they'll be more accessible. I guess in a country where resources are very limited, the complications of therapy with chemotherapy are not supportable either, and therefore any therapy which could be given which reduces those complications is likely to be useful. I did a little work in Uganda, and it wasn't even possible to do a full blood count for some patients. So in those situations, then you have to think, how on earth can you manage a tumor unless it has very little toxicity?
Thanks, thank you. We have got Professor Groton-Hughes here as well, and I had a chat with Professor Groton-Hughes going back 5 years ago. I know Professor Groton-Hughes and Dr. Cohen go way back than that. In terms of the neurosurgical training, do you think that the neurosurgical trainees should spend time in molecular biology or do a PhD in molecular biology, those with those interest in tumors, to make sure that we are not out of this ship? Professor Groton-Hughes and Dr. Cohen, thanks.
Well, Naren, I think that at least they need to have the understanding of what they are talking about and what they're reading in an histology report. I don't know if it is necessary to really spend time in it. As it is mentioned, it is better to spend the time in being well trained in performing the surgeries. But of course, you should. The same is the question, do you have to spend a year in radiology to really understand MRI scan or CT scan? I think anything that involves that part of neurosurgery so that you can talk to your pathologist, I think that's necessary. But I don't think they really have to spend time in it. They have to spend some time at home studying this.
Thanks. Thank you. Dr. Cohen, your last words from you, Dr. Cohen, your thoughts on all the comments mentioned and neurosurgical training in future. Thanks.
Yeah, I appreciate all the comments, and I would like to say that Dr. Grotenfuss is way too modest to be a neurosurgeon. He is one of the leaders in the field, and I take everything that he says seriously, but his humility is something that's unusual for a neurosurgeon. But I agree with him completely that I think we need to have some kind of knowledge about what's going on in the laboratory to be able to communicate and to be able to translate this more effectively for our patients. But I think the other thing, which we didn't spend a lot of time talking about because this field is so rapidly moving in the molecular world, is surgical judgment. And that's one of the things that, a patient where a radical or gross total resection will be the optimal therapy that comes at a cost. One has to balance that. And there are a lot of issues in surgical judgment that we haven't talked about. And I think that's probably the most important thing for a surgeon, which happens outside the OR.
Thanks. Thank you very much, Dr. Cohen, for that excellent lecture. Dr. Cohen is going to be publishing on this area, and once he has published it, he would kindly give us permission to put that lecture for everyone to see on our YouTube channel. Thank you very much again, Professor Cohen.